Mic checking. It works. It works. Good afternoon, everyone. My name is Monica Williams Harrison. I am an integrated care clinician, LCSW by trade, and I am here to facilitate the session this evening with my lovely co-facilitator.
Hey.
Hey, hey.
How you doing?
I'm good.
I'm Eboni Winford, and I am really excited to be here with my buddy Monica. I think we'll make a dream team, and so, yay.
Yay. We have an exciting group of panelists here that we kind of threw at them, like, we're not gonna tell y'all the questions, y'all just come and show up. You got this information. And
really
they still volunteered.
It really happened that way.
We do have a list of questions that we have asked the esteemed panelists this evening to be able to answer around regional communities and workforce. We have, because you see, it's many of them, but we wanted you to be able to hear multiple perspectives from multiple agencies so that this was not a siloed situation. So we have prepared questions that one panelist will start with, and then others will chime in, but we also have mics placed in the room for you know who. Our most important panelist of all, that is you. So we do invite you, if you have a question for any of our panelists, something additional to share. Those of you who listened to me this morning know my philosophy is no one person holds all the wealth and knowledge. It's important for us to engage and be in conversation with each other. So if you have a question or something to share, please stand up at the mics. There's one on the left and one on the right, so that we would be able to recognize you. All right? Thumbs up if everybody is clear. Everyone's here. Okay.
Okay.
Okay, we're in here. All right, perfect. So we are going to get started here on my right with the panelists being able to introduce themselves.
Twitter style, original Twitter, 140 characters or less. No pressure.
Got it.
Yeah.
Hello, I'm Kim Schuler. I am the CEO for the Arkansas Behavioral Health Integration Network, and we are putting integrated behavioral health across the health continuum in Arkansas.
Hi everyone, I'm Matthew Tolliver. I'm the Assistant Director of the Institute for Integrated Behavioral Health at East Tennessee State University, and we're housed in the College of Medicine in that setting.
Hi, I'm Diane Powers. I'm the co-director of the AIMS Center at the University of Washington.
Hi, I'm Amanda Garlen. I'm the lead clinician for the Philadelphia Integrated Care Network underneath the Health Federation of Philadelphia. We support expansion, training, and fidelity for primary care behavioral health in the region.
I'll take one of them. Hi, my name is Jennifer Yturriondobeitia, and I'm just AKA Gen Y. I am the CEO of Cornerstone Whole Healthcare Organization, and we also are the fiscal agent for the Idaho Integrated Behavioral Health Network, which works on the integrated behavioral health workforce and other kind of projects to help improve core competencies for integrated behavioral health providers.
Good. Hi, my name is Kara Hill, and I am the director of the Integrated Healthcare Initiative at Mental Health America of Greater Houston, and we work on a systems level to partner with our State Health and Human Services Commission, payers, and providers to create an atmosphere within the state of Texas that supports integrated behavioral health.
And you all know me now. I'm Julie Oyemaja, and I'm the Executive Director of the Interprofessional Primary Care Institute. We focus on building a strengthening each other culture within healthcare, and particularly strengthening interprofessional primary care teams reflective of all people and diverse needs, building teams that can support the whole biopsychosocial, cultural, and spiritual health of all people served.
Thank you, thank you. Most of us have used Twitter before, so we did a good job.
You made people nervous.
Y'all did great, you did great. All right, so we're gonna jump on into it, okay? So you all had a chance to at least look at the questions, and some of you said, you know what? I don't mind answering that one, and some of you didn't, so we got some questions for you too. So Jennifer, we're gonna start with you.
Gen Y.
Gen Y.
Right.
You. Okay. How were your networks created, and who determined the need?
So our network was it was created because it was a bunch of us that had been trained by like Patty Robinson, Kirk Russell, and over the years, there were a handful of us in Idaho that knew the model, knew what it should look like, the framework, but there was only a handful of us. And we got together, and it was very organic and very grassroots, and we thought we have to have more consistency in regards to how we're training, because we're seeing workforce that was failing in primary care, just lack of understanding of the fidelity and the training that they need to have when they're in primary care. So organically, we developed this volunteer group of people, and we started developing the Idaho Integrated Behavioral Health Network. And then we started to develop more training that was more affordable, and it was more of a workshop style of training and we're very rural and very frontier. So if someone has to leave for a conference, they're having to leave for a full week. And so we thought, let's keep the conference affordable and the content very deep so that they can take that back to their communities. And so that's really led to 3 hubs, because regionally we're very different from north, south, east, central, south. And so we created these regional networks within those hubs so that we were more culturally appropriate for those regions. Did I answer all your questions?
You did.
Yes, you did.
I just want to highlight the fact that you included the cultural appropriateness. I often think that when we're determining need, it's based upon what we think our community needs, and the fact that your network intentionally created networks that responded to your community, I think is what makes it strong and effective that way.
Thank you.
Anyone else on the panel would like to let us know how you were created in terms of your organization?
So George Fox University was an early adopter of training psychologists in the primary care behavioral health model. And gosh, probably now about 15 years ago, they started a community. The community was integrating behavioral health clinicians in the primary care clinics in our rural areas of Yamhill, Marion, and Polk. There was a lot of integration of behavioral health clinicians, and because George Fox had a little step ahead in knowing about the primary care behavioral health model and training our students in that model, there was a grassroots effort of people who were just trained, like myself and many other people who are in this room from George Fox, who would just come together because they wanted to in the summer, and had a boot camp every year. And every year, people in the community asked us to put on this boot camp for behavioral health clinicians to work in the clinics that were increasingly throughout Oregon integrating these individuals. So in 2017, the person who was leading, Mary Peterson, who was leading that effort, asked me to come in and work with that training program because it seemed to be meeting a need and just wanted to advance it further. So we had a think tank. We pulled together 10 organizations, many who are probably represented in the audience today, and we said, what are we doing that is working in training the behavioral health clinicians for your clinics, and what are we missing? And they gave us a ton of feedback, and one of the most important bits of feedback that they gave to us is that behavioral health clinicians love to be trained by physicians and other professional types that they go to work with. And we said, aha, interprofessional. And interestingly enough, at that first boot camp where we took on an interprofessional approach to training behavioral health clinicians, we had 29 different professionals who came of their own time to teach behavioral health clinicians about what it is to work in primary care. And one of those professionals actually worked for the Oregon Primary Care Association, and she said, Julie, this is amazing. There's a grant that just went past our desk. Let's partner on it and let's create something. And from there, we put together over a month's time a grant to fully fund our Interprofessional Primary Care Institute for its 3 years of startup, and we're moving into our 4th year.
So I just wanted to piggyback on Gen Y a little bit, just because she's been so inspirational for us getting our start in Arkansas. So we started 3 or 4 years ago, and we had the opportunity to be part of a CPC Plus initiative. And CPC, we were part of both CPC, which was 5 years, CPC Plus, which was another 5 years. And in that time, we had an opportunity for our stakeholders to meet, to come in and really look at what are some of the unidentified healthcare needs of our community of Arkansas. And with that, one of the #1 things that we identified that was not being addressed was behavioral health. And so with that, there was a passionate woman that I happened to meet. Her name's Dr. Patty Gibson. She's here in the room today. And she and I got together and spent countless hours talking about how are we going to meet the needs of rural Arkansans and the behavioral health crisis. So with the stakeholders, we developed a integrated behavioral health work group, which morphed into meeting Gen Y and talking to her at conferences like this. She donated countless hours to provide us, and also connecting with many of you out there at the CFHA network. We really learned from you, learned from each other. And so it was really a multi-stakeholder network, and then people such as the people here today in the room and the people on the stage who really helped and inspire us.
So what I've already heard from all 3 of you is the importance of networking with each other, and most importantly, the people in this room. Reach back as you're moving forward, you're plunging forward ahead in integrated care, reach back to those. I know we had a newcomers orientation, reach out to some of those individuals and network.
Well, I would say this, pay it forward. That's been kind of our motto.
Love it. Go ahead, Matt.
I can speak a little bit to our organization. We're in Northeast Tennessee, which is pretty rural, and I'm in a College of Medicine there at East Tennessee State University. And before a couple of years ago, we have pediatrics, OBGYN, family medicine, and internal medicine. Not all of those departments had integrated behavioral health services, and the ones that did were pretty disconnected and didn't have any way of communicating back and forth with each other, and didn't really have a connection to other behavioral health organizations in the region either. And so Jody Palaha, who is our director, and I went to our dean at the College of Medicine and pitched this vision to create an institute for integrated behavioral health that would have the aims of really driving integrated care service delivery for our College of Medicine, but also training behavioral health providers in that setting too, in those primary care clinics, and training medical providers in team-based care competencies, doing research, and then importantly, forming some regional collaborations and regional networks. And through that process, we really found that, gosh, it's important to put some FTE and funding behind a position like this if you're going to create a regional capacity building entity. It's hard to do that just in between warm handoffs if you're just in a clinical service role. And so, having that be in somebody's job description where they can put the effort and the thoughtfulness behind that to sustain those types of partnerships and networks was, I think, something that helped really have us be successful, because we were able to negotiate some of that into our roles within the College of Medicine, that time to work on a project like this.
I'm going to bounce the ball, Matt, now that you said that about regional network capacity building, to Kara. Kara, I'm wondering what your thoughts are around why regional networks are important, why an organization like yours needs to exist.
Well, again, I work at Mental Health America of Greater Houston, and I am the director of our Integrated Healthcare Initiative. And what we do is, we're not a service delivery provider. We don't provide care. We work on a systems level to help support other practices and bring to the table payers, as well as we're working on creating influence with HHSC on supporting integrated behavioral health. And I think our organization is really valuable to that because no one entity can do that on their own, right? And integrated behavioral health is so hard. It doesn't come natural. It's not easy for us. And those that are service delivery providers are out there working so hard to implement this, to do this. We want to be your advocates. We, like I said, work with those payers to be the advocates. We also listen to our organizations, our stakeholders that we work with, and create the workforce development trainings that they're asking for, create the opportunities for the workforce to be trained, and then placed in primary care. So we're valuable in this space because we can bring people together that providers can't always. We work as the middleman too, or the middle person, because we work with providers and payers. We have a value-based contracting learning community where we bring providers and payers together in the same room. They wouldn't do that on their own.
No, they would not.
They, both feel some kind of way about each other. So we're able to do that and be a neutral party and hear from both sides and relate back to both sides and talk about how we can get to the same space and work together and find the similarities that all of us care about.
Kara,
I don't know if I answered that question.
Yeah, what are some training opportunities that you all provide that contribute to building the workforce through these networks that you're creating?
So we provide a lot of trainings. We do just entry level, like what is integrated behavioral health, the 2 models, how do you pay for them? We have a series of Project Echoes that we've developed with experts telling us what needs to be in there. We have a closed group that we work on collaboratives called a Breakthrough Series Collaborative, which was developed by the Institute on Healthcare Improvement. So those are the things that we're currently doing. The other really exciting thing that we're doing that we are going to start is a behavioral health consultant certificate course. This is not for students that are getting their master's degree, it's for existing licensed providers. So it is a 10-month course. Our application will open on Monday. It will start in February 2023, and we will have experts like Dr. Eboni Winford, Dr. Stacy Ogbide, and others in this room. Becky Scott will be our faculty. And we will be teaching behavioral health providers that are already licensed, already out in the community, and need to know how to operate in primary care. So we're starting that. And by the way, when it comes to diversity, equity, and inclusion, we're just embedding that into our echoes that we're doing right now for behavioral health providers, with our topics being a behavioral health provider's role in diversity, equity, and inclusion, behavioral health provider's role on social determinants of health, vaccine hesitancy, things like that. But those topics will also be embedded within our course that we will launch in February 2023.
Well, I, for one, am excited to hear it. I see how you did all them plugs, Kara. But I, for one, am excited to hear it because that's one of the things that I think is missing along the way sometimes, is that the diversity, equity, inclusion, and that spirit of belonging should be woven through and not this separate entity, this standalone training or something of that sort. So I'm glad to hear. Okay.
Thank you.
Amanda, want to piggyback?
Sure. So PICN was started in 2006, and there were only 5 centers with 12 BHCs. We were bringing in experts to teach us about PCBH and how to grow this. And fast forward, 2022, we're at 60 centers with 150 BHCs.
Clap, y'all.
I didn't do that. Don't give me credit. But now we have we ask the BHCs how they want support. We do monthly free CEU trainings for the BHCs across the network. We have a listserv because we know that some BHCs are in centers where they're the only BHC there. And so now they can reach out to 149 of their now closest friends to ask for advice and ask for recommendations within the Philadelphia network. We use the SAMHSA IPAT assessment, and we go out to center sites and meet with the interdisciplinary teams to make sure that they're meeting fidelity to the model and to give ideas for how to improve. And on-demand technical assistance to all of our centers for not just the BHCs, but for administration, or even just advice on how to talk to administration in placing yourself and making sure that you're being more, having more model fidelity.
So the AIM Center, we provide training and implementation support to organizations that are implementing collaborative care, and we've been doing that for the last 18 years. And largely, we have done that organization by organization, and mostly we've worked with individual healthcare organizations, although they may be really large and have multiple sites. We largely have done that. We've had a couple of opportunities, though, to work on initiatives that really brought together groups of clinics, and we really see a lot of value in being able to do that so that both in terms of the implementation coaching, so at a systems and at an organization level, being able to learn from your peers, be able to go down the implementation road with folks who are doing that as well is really valuable. And then also at the clinician level, kind of what you were just saying, really helpful to be able to talk to your peers and, talk with them about what they're doing in their practice and where they are in their learning, and really support each other in learning. So I think having the opportunity to have networks of learners and of implementers, I think is really valuable.
Well, listen, Diane, you have the mic, so here it comes. I am interested in what outcome measures do you have and what impact does that have on our integrated care community?
Okay. So I'm going to speak specifically to a network that we've created recently over the last 3 years. We've had a program where we have brought on 3 separate cohorts of organizations that are implementing collaborative care in rural areas, and I think it's particularly important to be able to do that for rural clinics because they're so isolated and they often sort of don't have a natural peer network of other organizations and other that are going down the same road as them. As part of that initiative, we are doing a pretty robust evaluation as part of that, and we're going to be able to look at things like patient-level clinical outcomes, processes of care, clinician burnout, clinician attitudes, and things like that, and be able to see those things and how they interconnect in terms of their implementation journey, and then how that affects those kinds of measures and those kinds of outcomes.
Okay. Anyone else have some outcomes? Julie, what you got?
Yeah, I ran across this wonderful major called the Assessment of Interprofessional Collaboration. I think it's a little bit longer than that, but it assesses interprofessional collaboration in healthcare teams. And so we provide that at each of our events just to get people thinking about what it means to work together. And that's the place that we want to play. We really focus on the unit of primary care, like who is in that unit. And this is a bold statement, but I believe it very strongly. And I believe that primary care clinician and an MA and sometimes a nurse is not the unit of primary care in the future. A primary care in the future, and really should be now, it needs to include a primary care clinician, a medical assistant, and a nurse doing complex care management and triage, and also include a behavioral health clinician and include a community health worker all the time, everywhere, and with few exceptions.
Period on that. Just period is what you wanted to say at the end of that, the way you said it, Julie.
Boom. You know, I wanted to say that really now for 10 years, and I've said it a few times, and I'll be honest, I've been discouraged, but I share it. So thank you very much for that encouraging, strengthening moment of giving me applause for that, frankly, from the deepest of my heart, because I feel it very strongly. I've worked in federally qualified health centers for so many years, and I cannot imagine doing primary care without those team players every single time I do work. So thank you.
So outcomes data is a really interesting, it's probably something that we talk about all the time, but we have not really made a lot of advances, especially with behavioral health, when it comes to how does that link for us in regards to our part in the performance metrics, especially when it comes to like incentive-based or value-based contracts or payments. And I think that we have a long road to develop those outcome metrics. And I think for us as a group, we have to know the difference between the clinical fidelity and clinical measures that binds our practice, but also the metrics that need to be combined with the payer outcome metrics, and how do we measure that together, and also how we can be at the table having that discussion about outcome metrics and where does behavioral health intersect with that. So I didn't really have an answer for it, but that's really more of a commentary.
No, Gen Y, that was good, because guess what? Now my question is, how do we get to the table, right, with the payers? So any panelist member up here who has had to do that, those of us who are in this integrated care community who are trying to get change and trying to advocate, we don't have a seat at the table. How do we get to the table? We want to eat too?
Yep. So how to get to the table, I don't know if I have the answer, but I can just at least tell you how we've done it, in that I think, one, we have to be within our systems. Usually behavioral health has the worst priority for when we're in an organization to get data, get reporting, because we aren't top priority when we're in a primary care or a healthcare system. That's hard to overcome, but one of the things I want to sort of ingrain in everyone's mind is, as I was listening to some of the forums today, and the things that we talk about in regards to provider experience and provider burnout, care team burnout, those are really important. But the other things that we talk about in regards to the patient experience and patient perception of care, I'm going to tell you the payers will listen now. The new CMS and HEDIS and STARS measures, it's almost 60% of their requirements. And we are one of the few workforce that can really work on patient and provider experience. That's how we get to the table. Those are the measures that we need to help primary care figure out how the patient experience is and how do we quantify that for them. And it's gonna all based on HCAHPS scores, unfortunately, but how do we get those filled out and get that information to our payers? Sorry, that's not a perfect answer, but it gets you somewhere.
Gen Y, for those who may not know what like HEDIS and HCAHPS scores are, can you let us know what those are?
Yeah, they're CMS measures that help sort of determine a rating and performance of a payer system. And that's how they are sometimes funded or are provided kind of additional benefits to help their membership.
Kim?
I was just going to add on to that. You know, I think we're fortunate in Arkansas. One of the ways that we've been able to make it to the table is we've participated in some of the value-based programs with CMS, such as CPC Plus and Primary Care First. I think another key component is that the payers are at the table, as well as large health systems, hospital systems, healthcare providers, individual primary care providers. care coordinators, all levels of the care team, as well as patient representatives. And so they're able to hear firsthand the struggles that patients are having as far as access and the difficulties that arise and the need for meeting their mental health needs in primary care settings. Another way that we have been able to, I think, get to the table is we've had an opportunity in Arkansas. A bill was passed for a mental health caucus. And so we've participated in this mental health caucus and brought integrated behavioral health to our state legislator through education, through presentations, and payers have been present there and have heard us bring in the importance and relevance of integrated behavioral health. So I think from state government levels all the way down, we've been able to communicate that message.
So one of my favorite movies is Shawshank Redemption. Have you ever seen this movie, Shawshank Redemption, right? And the guy that gets out has his little hammer, right? And so sometimes we have to be like him and just keep hammering and keep hammering and keep hammering. You can't give up. And I don't think we have that long of a road, to be honest. I think the time is now. I think providers have a voice, and we no longer need to be the victim of the payers. Payers need this.
Please clap. Clap it up for that. Please clap on that.
Payers need this, and payers want this. I'm in conversations with them a lot. And I know it's different in other states than it is in the state of Texas. And even if the state of, it's Texas, let me tell you. Even if the state of Texas has some mandates, and they do, for our payers to get into value-based contracts, our payers find the easy way out, but they still want to do more. They do. And providers need to come to the table, not as, what do you need, payer, right? As like bowing to the payer. Providers need to come to the table, especially if you're doing integrated behavioral health, and tell the payers how it makes a difference in their outcomes that they care about, how it makes a difference in patient satisfaction, how it makes a difference in improving health. You can influence those physical health outcomes with a behavioral health consultant. It's no longer, like, you don't have to. Our payers don't even know that integrated behavioral health improves physical health outcomes. I repeat that to them again and again. I have said it to our payers 3 and 4 times, and then I get them into a meeting, and they're still like, wait, why are we looking at mental health outcomes? I'm like, because that's not what's in primary care. It's physical health outcomes. Tell your payers what you can do. Take charge of this, because you can do it. And the other thing that we do is use FOMO, right? Do you know what that is? Fear of missing out, right?
Fear of missing out.
Thank you.
Yes.
Somebody else had to tell me that, because somebody else that's like 20 years older than me told me that. I was like, what's that mean?
You trying to say I'm old? What's going on, Kara?
So we tell one provider, don't you want to come to the table? Community Health Choice is at the table. And then we tell another provider, don't you want to come to the table? Blue Cross's Blue Shield is at the table. Don't you want to come to the table? United Healthcare is at the table. And they're like, oh, yes, I guess we should come. FOMO, it works.
Write that down, everybody. FOMO.
FOMO.
It works. But you just made me think of the late, great Shirley Chisholm, who said that if you are not offered a seat at the table, you bring your own folding chair and pull up. I do. And Kara just told us to bring our folding chairs. So if y'all want some change, get your folding chair.
They'll scoot over and make room for you.
Or you gonna sit on somebody's foot.
Yeah, I'll sit down.
But get in there, y'all. Yes, we are a little bit radical, but that's what it requires for the change that we're talking about. What is also going to be important is to make sure that we build a workforce that reflects the people we serve. So Julie, I want to ask you, how do you prioritize and integrate training that prioritizes inclusivity, equity? And I don't like the word equality. I could care less about the word diversity because that's just a checkbox. right? Like you can't just say, ooh, we got 2 of them, we're diverse now, screw that, right? And inclusivity gets on my nerves too if I'm gonna make it plain, because why do I need you to invite me? And how do you determine if I can be included or excluded or not? So let's focus on like equity. How do you get that into the training that you do? I did have to slide in a mic drop because these DEI things get on my nerves, y'all. It's the E that matters for me, but let me just leave it at that. But Julie, what you got to say?
Yeah, you know what? Representation matters. It does. Representation matters. And let's look around the room right now. Are we there yet?
No one's shaking their head, Julie, but I'm gonna go with no.
I'm just gonna say it. I'm sorry, but let's look at this panel.
Mm-hmm.
Hey, girl, hey.
Sorry.
Hey, Julie.
Right.
Representation matters. It matters. All people matter if we're serving all people. 67% of our leadership identifies either with Black, Indigenous, or other people of color community. People matter. If we're serving all people, I talk about primary care, that's where I serve. It's all people, all people, all people, all people. We can do better.
Well, let's get in it. Oh, I'm sorry. Where your microphone at, girl? Oh, Julie took it. Well, I was getting ready to say, so my question for the entire panel, not just Julie necessarily, is, so all people matter, okay? We're working on workforce development. We just talked about look at the room, right? So what are we doing, or what strategies have you utilized to try to enhance the workforce so that there are individuals in the workforce who look like the patient population that we are serving?
And before you all answer, I want to give a little caveat that recently, can I?
Have at it.
Okay. Recently, each of us have had to have a very invasive surgery, like literally invasive, cut from top to bottom.
And the
exact same surgery, like incisions from sternum down to pelvic bone, okay? I live in Knoxville, Tennessee, and I'm not sure if you know the statistics about like Black women's health. Receiving care from someone who looks like me can literally save my life. There was no one in the city of Knoxville who looked like me who could have performed my surgery. I did have access to the chair of the department, and he was a white man. I didn't get comfortable until he acknowledged that rates of cancer, the type of cancer that they thought I might have had, are significantly greater in Black patients compared to the rest of my patients. He knew he didn't serve people who look like me. I was terrified, y'all. I had a Black anesthesiologist and a Black nurse in the OR who was like, I got you, girl. But I was terrified. Monica had to like move mountains, like fight to get a provider who looked like her.
9 months.
To fight, because no one listened. And there is simply not a workforce that looks like us. We should not have to undergo significant invasive surgeries fearing that we might not wake up. So just simply stating, like, we all matter, we know that, girl, we know that. But how do we make people care? How do we get people here with us so when we look around the room next year, I see people who look like me? I can close my eyes on a surgery table and know that someone who looks like me, who statistically is going to be more likely to keep me alive, is going to be the one doing it. How do we get there? That's what I want to know.
Yeah. Well, for one, we need to accept the fact, or not accept it, but come into acknowledge the fact that we do not spend time with people that do not look like us. It is a tendency for human beings to spend time with people who look like them. This is something that is true, and we will not move forward until we acknowledge that we're doing that and we make efforts to not do it anymore. This is what we're doing. This is what we continue to do. I feel very blessed that early on, I found someone who I married who doesn't look like me. And people have become woke. That just means you open your eyes. You're not sleeping anymore. And you see that there is a difference between the life that I live as a white person and someone who does not have white skin. And you wake up to that. And that happened for me when I was 24 and I married my husband, and it was a slow process. There's a lot of work we need to do here. And for me, it comes to making a decision that I'm not going to continue to do the thing that as a human I tend to do. I'm going to do something different because it matters. Representation matters. And that is something that we all can do. It is not that complicated. But we have to do it, and we have to do it intentionally. But we can do it. And one really easy way to do this, who all out here is on LinkedIn? That's the world, man. That's your place. That's where you make some new kinds of friends that you may not see every day. Make some new friends. Representation matters, and until we are associating on an everyday basis in a way that doesn't look like the way we're associating now, we're not going to make progress. But from me, it's not that complicated. And so that's my answer.
So there's some individual roads, for sure. Many of you on this stage and some of you in the audience are gatekeepers,
Yes.
right? And so we're not just also talking about equity in terms of racial equity, right? I can tell you countless stories of clients, patients that I had that identified as LGBTQ and couldn't get the services they need. They couldn't get the medication, right? So this is not just a racial equity thing. It's equity in general, right? And so as the gatekeepers that are developing curriculum, right? So y'all know this ain't no, I know half of y'all up here, this ain't no shade from me, but developing curriculums, creating training programs, right? Like you all are doing astronomical things. Yes. How are you making sure that in the midst of this, that you are creating curriculum or creating training programs that are taking into consideration equitable principles? Kara?
We work with people that are smarter than us and let them tell us what to do. Right? We work with Eboni Winford. We work with Dr. Stacy Ogbide. We work with people that don't look like me. So that, because I don't feel like I could ever understand what that means fully, right? So we have faculty of diverse backgrounds. Because our students need to have instructors that look like them, right? Our high school students need to have teachers that look like them. So I wish next year you could have the audience look different, but I don't think it's gonna happen that quickly. I know. Besides my integrated care work, I work in a community, well, I don't do it. I have somebody that's definitely smarter than me. And we're working on building mental health and resilience in a specific community in the Houston area that's pretty much a forgotten community. And so the goal of our project is to work collaboratively with the community to support mental health and wellness for children and youth and their families of color. So that's our initiative, and we ask them what they want and need. And the disparities there are just astronomical. It's predominantly Hispanic and African American. The lack of interpreters in the schools for the Hispanic children, where children are interpreting for each other to take tests. It's just devastating sometimes. And the resilience of these youth, we have a youth advisory committee where we listen. We have they wanted to do it weekly, but we were exhausted. We're doing it monthly now, where we just have an open forum for them to talk, right? We have to be able to go deep within these communities and hear what they need. And right now we're going to be working with the youth and their families on changing policy, right? So we're giving them some understanding of how they can be empowered to change the way the school system operates, because it's inequitable. So you have to go deep, and I don't think it's not easy or pretty, but you have to be willing to look at ourselves and how do we change too.
Listen to 3 things that she said, and I want to make sure you heard them. We listen, we ask what they need, we ask what they want. And if they tell you they don't want you to do it, don't get sad, just walk away and respect that. But you listen first. You don't just invite yourself into the space to try to create the equitable positions. You listen for the need, which is why that first question we asked was, how did you create your networks and who determined the need for your network? Yeah, it's the listening and the asking permission to join in that space.
Gen Y?
I have a slightly different perspective of.
That's why you up here, Gen Y?
Yeah. I work in some pretty rural, very frontier communities most of my life. And I look at how do you make these types of changes? How do you change people's minds? It's very hard. And the thing is, everyone brings something to the table, whatever your color is or whatever your gender is, whatever. And I think the thing that I've learned probably the most in working in some very remote, very conservative communities, in that you have to be a part of the community. You have to develop relationships in a way that makes sense to them, because sometimes when you charge at them and tell them what you're not DEI or whatever that may be, they're going to look at you very strangely. And you have to be a good role model and be that change agent, I guess, if I know that gets used a lot, but I feel like we've made a lot of progress just being there and being part of the community and listening, right? But also not being, they have their own culture. I married into a very deep ranch culture, and it's a very different culture. I have to respect that. And it may not always be a fast change, but I've loved every community I've worked in, and you have to love that community. If you're gonna be the change agent, you have to be a part of that community. So yeah, do I like some of these things that happen? No, and change is very slow, but you have to respect the culture that you're in, but you also have the ability to make change, but some will be, I'm a little more silent about it, and I do things that help the community and make those changes in a way that kind of changes the structure, but it may not be very overt. But that's my style, right? And your style is gonna be different, your style is gonna be different, and that's okay. But we all work towards the same goal.
And for PICN, we also do director meetings where back in the day there were no behavioral health directors. And now that there are, we're always talking about recruitment and openings and how do we recruit more and what does that look like? And my thinking is always workforce pipeline. What does that look like? How do we start in the communities and help the community realize that this is a position that they want to be in, and how do we get people in that position? And integrated care is that place, right? We're working with community health workers taking off my PICN hat and putting on my BH director hat. In our site, we have integrated meetings with our community health workers because they're essentially social workers. They already do the work. And so how do we actually support them in getting the degrees, to get the letters, to support them with the supervision, and asking them what support and what training do you need, so that we can build them up from the community. And then we will see our BHCs looking differently, and we'll have a much more variety and choice in who we are bringing on as our BHCs, as opposed to fighting each other's centers to get the one LCSW applying everywhere.
I think that's a great point, and I just wanted to echo what you said, because I think especially in rural communities, there's a sense that if you want to retain the workforce, then one strategy is you gotta find people who are here who already have a sense of the values that the community holds and have a sense of the sense of place in that community. And if you have those strong training pipelines, I think that's one way of being able to recruit and retain folks in a workforce shortage area, if you're able to find those people that already call that place home and want to stay there as well.
My little add-on is, and then working within the schools that are training and pay people for field placement.
Oh, you hit a hot topic.
That part.
Well, since majority of the panel responded, I'm gonna still toss it to you first, and then Diane.
And the question is about trainings.
Mm-hmm.
Wonderful. So we at the Arkansas Behavioral Health Integration Network, we've had a great opportunity to collaborate with Blue Cross Blue Shield of Arkansas, as well as two university MSW programs. One of the things that's happened is, as you can imagine, we've been talking about, there's this huge need for trained behavioral health consultants, and where are we going to find them? We don't have a lot of people who are trained in Arkansas. And so, fortunately, the payers have heard us talk about this now for probably 3 or 4 or more years, and really realized we have a mental health crisis in Arkansas, and how are we going to grow the workforce? And so they have been gracious enough to provide an endowment to 2 of our academic institutions to train behavioral health consultants. They're also paying for field internship programs, and they are field internships, excuse me, and they're also paying for them their tuition. And yes, it's exciting. It's become a competitive program. And one of the things that we're doing is looking at not just having people centrally located in Arkansas, but we're looking at how can we spread this into rural areas, and how can we have this be an inclusive training program. And so this fall, we launched our first boot camp and have started training MSWs in integrated behavioral health, and now we are also providing coaching and training this entire year. We've also worked with the primary care provider sites so we could provide them training. One of the things that I've heard and experienced myself is when we put a BHC in a primary care clinic, a lot of times the providers don't know what to do with them. And so we have to provide them training so they have some ideas on how do I use this new resource on my care team.
Thank you. Diane?
Yeah, so I'll start by saying that I think, despite the efforts that we've made, there's a lot of room for us to improve. And I think that it's good that we're having these conversations, because it's really essential for all of us to bring this to the forefront of our awareness. And so I know that we can improve. The things that we have been doing in terms of our training is, one of the things that we train on is problem-solving treatment, which is a psychotherapy that was designed for primary care, and we do provide training in that. And we're really lucky that we have the ability to provide that training in Spanish. We have a Spanish-speaking trainer who's able to listen to the tapes and provide the training for people who want to do that training in Spanish. And I think that, we're happy that we're able to do that. And one of the things that we just started doing this year is providing scholarships to people who come from racial and ethnic minority backgrounds that are underrepresented in medicine for things like problem-solving treatment and behavioral activation. Sort of acknowledging that those resources are not equitably distributed and not equitably available to people. So we're doing that. And then the other thing that I'll give some credit to, we have a DEI committee at the Ames Center, and one of the things that they have put their attention to for the last year is creating a toolkit that's for all of the trainers and for all of the people who are creating training materials as subject matter experts around the language to use. Language is so powerful. And we work with organizations that are all across the country, and some of them are very advanced in terms of their understanding of diversity, equity, and inclusion, and others less so. And so we think it's important that we make sure that we're speaking with language and modeling that, and making sure that our materials are using language that is equitable and inclusive.
Thank you. So one of the things that you all don't know, but what we did say to the panel is, it's okay also to not have the answer, right? Like, it's okay to not know, or to be able to say, you know what, we're not really doing anything with that. Yeah. That's honest, and that's authenticity. And then it's, okay, so where are you gonna start? Where are we going? Say your name first so we know who you are.
I'm from Minneapolis. I'm sorry, is this too loud?
Nope. Absolutely not, Rebecca. Girl, do you hear me?
I can be louder. Minneapolis is very, it's a diverse city in the sense that we have pockets of many, many different cultures that do come together. But unfortunately, our school system has produced a lot of disparities and continues to do that. And I say that because I work in an organization that has only recently started IBH. Unfortunately, all of us are white women, this is more of a comment than a question, but I think oftentimes, like when we started our intern interview process this year, we were really excited about the diversity of the candidates, and then we ended up with matching with white women. And as frustrating as that is, I have to look back and think about, like, what was there. I mean, obviously our group is entirely white, and that is a reflection of a lot of different things. But I guess my question for the panel and for this organization, this is my first time here.
Welcome.
Thank you. And I love it, but I want to say that I think that there's something that we can do as an organization to support people of color who are learning, who are new to the field, whether that's through scholarships or, again, asking them what they need to be able to come here, so that our organization, as an example of this, or as defined by our conference, reflects, number one, the people that we want to serve, and the new providers that can bring more to the table. So I'm just wondering if I know that there used to be a scholarship program available. I wonder if that's still available, if there are other things that we can do as an organization.
Rebecca, do you mean a scholarship for attending CFHA?
Yeah.
So I'll let Neftali Serrano, I don't roll my R's like him, but I'll let him address that part. But I will bring to the panel, what I hear from Rebecca is we had a diverse pool of applicants, right? Like a diverse pool of applicants to enhance our workforce. But we ended up with everybody who looks the same. So any strategies, suggestions, lessons learned about those types of situations and what to do? Where might there be a breakdown? What's something that maybe needs to transform?
Well, the leadership needs to be representative and not be completely white. So the first thing I would be targeting is leadership.
I think another. I was thinking, another thing is if there's gaps in the training pipeline in the place that you are, you may be losing some great future workforce folks to other regions, right? That, like in our region, we noticed, gosh, we don't really have a lot of psychology internships. So everybody that comes to our graduate school, that's awesome, that has been vetted, that brings a lot, they leave, right? And maybe they don't come back again. And so, if you're a training program, sometimes I think if you think about it in like an assembly line style of, okay, my job as a training director is to kind of get them a good educational experience, but then after that, I kind of don't have any more responsibility and they go to the next part on the assembly line, then maybe we need to be kind of, I think what we're trying to do is kind of look down the assembly line and look for these gaps in the training and make sure that there's actually jobs in our region at the end of the line for these folks. And so, because I think a lot of the, if you're just trying to advertise for a job, then you may or may not get matched with certain people. But if you can look earlier on in the line and kind of identify people that you want and that would be a good fit for your organization and make sure you have that complete that sequence of training, then I wonder if that could be a potential solution in retaining folks that you want to keep.
So I'm actually from Minnesota as well, but I'm from northern Minnesota. And I understand, the first thing I'm going to say is thank you for coming into the field. Whatever color or, gender identification you have. So I think that's the first thing. The thing is, if you know where you're going to be working and you know the population that you're in, I know like in Minneapolis there's a fairly large Hmong population, and I know there's now quite a large, with the refugee population, you have a large Somali, and my thing would be is you can't change who you look like. I can't change who I look like. But you can learn about the communities that you have to work in, learn the customs, learn and embed yourself or get to know the community so that you accidentally don't offend them by saying something or eating something. I don't know what it could be, right? But I work in such rural, low resource areas, I'm just happy to have somebody. And so I can't change your identity to make it suit for the community, but you and anyone that comes into this field can do better about educating yourself and talking to the members of that community about how to be a better community member or a better person with this population. I think that's the best advice I can give you, because it's so hard to change a whole ideology of things, and you can't change how you look. And so do the best you can in learning about those communities and their cultures and customs and abide by them. That's my best.
I have some questions. Who was that woman that just spoke? I have some
Rebecca.
questions for you, just to understand. So you said these students that were matched with you were all white. Is that accurate?
Yes, this was our first year in an internship program, and we had...
Okay, so matches come to you because you select people and then they decide to be with you. Is that accurate?
Yes, so we had people of color that we interviewed.
Yeah.
But they did not choose.
Yeah, they didn't choose you.
Right.
Who else interviewed them? Who interviewed them?
It was just myself and one of my colleagues.
Was she white?
Yeah.
Yeah. Do you have other people at your organization that are not white?
Kara's got a line of questioning here.
I'm sorry.
On it,
I'm
y'all.
sorry. I just...
No,
But these are the
don't
questions we need
apologize.
to ask.
I'm laughing because my entire... No, really.
No. No
not-
physician?
Not within, so within IBH, within our integrated behavioral health program, and within,
Are physicians in your program?
Yes, we have physicians in our program.
Medical assistants?
Yes.
Are any of your medical assistants people of color?
Yes.
Take them with you.
Okay.
They're not going to want to match with you because you don't look like them
Yeah.
either, right? So first of all, if you're working on an interdisciplinary team, you should have interdisciplinary teams interview people that are coming onto your team, not just behavioral health. When you interview for anyone, I'm not saying this to you, I'm saying this to everybody, take more than just your behavioral health provider. Take a physician, take a medical assistant, take a nurse, take someone that might look like them because then they're not going to be like,
It is team-based care after all.
I'm not going to be the only Asian person here, you know?
Well, and I will
whatever
tell
it is.
you know, I'm on the panel, but I'm not on the panel. I will say, I look at that. I do. When I'm interviewing, and those of you who know me know I keep it 1,000. I looked at that before I went where I went. I do. Recently at Ames, I paid attention. Like, there ain't a whole bunch of black people. Where the black people? It's okay. But what they brought in, so there's not any, right? I did my research. There's not a whole lot on the wall, and that's okay. But what they brought instead was telling me up front what they were doing. It was infused throughout the interview. They asked me questions about diversity, equity, inclusion, and belonging, right? So the fact that they're asking me means that, oh, well, maybe this is a priority for them. Okay, I can get behind that. Let me see what we're working with, right? So if I show up and you don't look like me, I at least want to know you care about me and that I belong in the environment that I'm going to work in, right? So even if you can't pull that MA because they're busy that day or whatever, but you should if you can, but they're busy that day or whatever, you want to make sure that your website, your marketing, your materials, your interview process, your application, any and everything that you can think of is infused with equitable principles, wording, language, all of those things.
Thank you.
All the gems.
I know.
Gosh,
I told y'all it was gonna be amazing.
I mean, look
I was
at
all
that.
nervous.
Look at that.
Naphtali Serrano with the R's. Hit me.
Naphtali.
Yeah, so I have too much stage time, so I'm going to be as brief as possible. So first of all, what was your name again?
Rebecca.
Rebecca. All you newcomers, see her example. That's how we operate at CFHA. First conference, she comes up, throws a bomb of a question. Great. The other thing I just want to say, yes. And that is part of actually being, of driving an equity agenda, is to not have an organization that doesn't allow people to rise through and bring concerns and issues up and have them become actionable, right? That's why we are a collaborative organization. That's why it's in our name. So, nice. The other thing is, I'm going to push back a little bit on this because I want us to get to the root of some of the workforce issues. And if we don't identify the problem at its root, we're going to have trouble. So, first of all, Rebecca, you could have done everything the panel said, and you still would have ended up with a white applicant. Why? Because it's a data problem. It's a statistical problem. Way down deep in the workforce pipeline, we simply don't have the numbers. So nationally, we're all fighting over a very small pool of professionals of color, whether it's in social work, medicine, psychology, psychiatry, etc. That is the reality that we face, right? So if we define the problem that way, then we understand that the solutions run way deeper than just internship level, postdoc level, practicum level even, right? Now, you compound that with our niche, which is right now a niche, but really needs to become a whole system where we are trying to build out a primary care level of care, and we're trying to attract a workforce to build out integrated care across the entire primary care system so that every clinic and every patient has access to this form of high-quality care, right? So we've got to attract people of color and people who are interested in doing primary care work when the workforce way down deep, and I'm talking at the bachelor's level of training, don't even know usually that this is an option for them to go in. So we have to dig way down deeper. I'll end with this. I think that the work that you all are doing is really important because you are giving voice to this as a workforce development issue in your regions. I want to ask, what are you doing to get way down deep into that pipeline piece? Because if we can't get down that far and entice people, all sorts of people, but particularly people of color, to say, I want to work in primary care, this is what I want to do, we can have all sorts of strategies to try to recruit people. We're still not going to statistically be able to represent the populations we serve.
It's a great question. I have a question. How many here are community health workers, peers, health coaches, doulas? If you could raise your hand.
Oh man, she's not in the room, but there was someone in the session with me this morning who, oh, if I find you, you know I'm gonna call you out.
Well, the reason I asked that question.
And she was a community health worker, inspired by her organization to continue along and get further training and education to stay within her organization. Oh, if I find her.
So our institute has three, we support many different roles that are making primary care more interprofessional, but there are three key roles, and I mentioned them earlier, that we have supported and continue to support. And that's behavioral health clinicians, well represented in this room, culturally responsive community health workers, and they come by different names, traditional health workers, peers, health coaches, doulas, and then nurse complex care managers. Those are three roles that we think we need a ton more of to do really good primary care that's interprofessional. So from what we are doing at our institute is that we support community health workers, and our community, which is largely behavioral health clinicians in this room, we can play a part in helping this newer community, this emerging role, the community health worker role in primary care. So as much as we are doing to support this role, which I think we are powered to do, we're gonna have more stories like you just shared.
I think to Naftali's question too, about even getting to the bachelor's level to generate interest, I mean, even earlier than that, I mean, if you think about the STEM fields, right? Like they're going into elementary schools and having camps and getting kids excited about that particular field. And we don't have any great solutions yet, but we've even been talking about like, how could you do a camp for high school students? Could you kind of reach out even earlier on, like the earliest possible in the pipeline to kind of generate interest in this field too, and provide that mentorship program along the way? Yeah.
I just wanted to add to that. So in Northwest Arkansas, we have a large Marshallese/Pacific Islander population as well as a large Latinx population. So one of the things the social work department did is, this is our first year of having these internships for integrated behavioral health, but they have identified someone who's Marshallese, Latinx, and they're trying to really promote integrated behavioral health in these programs and provide early education. They're also talking about trying to provide some education at the high school level for people interested in health fields, just to try to generate some interest. And so that's one exciting thing that's happening to try to address the pipeline issue.
Let's let Kara speak, and then we have someone at the mic, and then we have like 3 minutes left, but we're gonna get this in here.
We need to pay people more.
I know that's right. Say it again.
We need to pay people more.
All right.
Behavioral health providers are paid crap for what you do. Community health workers in the state of Texas, people can make more money at Walmart and Taco Bell. We need to pay people more. You need to work on policy and advocacy within your state and to increase reimbursement rates. You need to pay executives less and frontline staff more.
All these gems, Kara, like, that's why we're friends.
The one thing I would add to that is that we need to work on licensure issues too, because I think in our state, it's been a huge barrier to the workforce where people, you know, we hire them, we get excited about them, and then it's months before they can see patients because we can't get them through the licensure process. So that's something that we've been working with Tennessee, going to Nashville even and trying to do some advocacy around that to change that. And so I think that's another key that's holding us back, though.
I just want to add that one thing to his. It's not only licensure, it's the interstate.
It's being worked on, though.
The
interstate
that's got to be
compact,
taken care of.
it's being worked on. It's going to be some years, but it's being worked on. So what you hear is you got to go deep. There's also all this surface level stuff. You can't just be working in one spot. There's multiple areas and points to hit to get some transformation going and some change. At the mic?
I want to piggyback off of the national.
Tell me your name first.
Tracy. Hello.
Hey, Tracy.
Hey. So I think big, and the American Psychological Association does an annual state leadership conference. I think CFHA should have a state leadership conference that goes to Washington, D.C., has a seat at the table, and I went to one year, and you break off into groups and you actually talk to your politicians on Capitol Hill. You get appointments, and it's an amazing leadership conference. But I think CFHA should do something like that. Just thinking big.
Noted.
I was going to say, Neftali, you taking notes?
Yeah, he's coming. Here
and he's
comes.
coming up. Thank you all so much for your
and the panelists. Thank you so much.
Thank you for the gems. The mic drops.
Thank you. Yes. Can we stand up and give them a round of applause? Thank you very much. So I needed to cut the session off, not just because it was time, because I realized people were adding more work to my plate as they were coming up and making comments. So, no, great comment. And if you're interested and passionate about that, we are starting a policy cohort, a group of folks who together will work together to build up their skills in advocacy and to hopefully partner with organizations like APA or AMA or AFP to do some of this sort of policy-based advocacy work and enact some of these things, hopefully, that we see up here. So, great idea. Go to that session. Julie Geiler on staff is leading that session tomorrow. I believe it's tomorrow afternoon. Just look it up on policy. I hope that you leave here this conference and tonight inspired by what's here. I know it feels daunting, but I want you to leave not daunted, but inspired. Because part of the reason why we put this together, I'm sorry I have my back to you, is these are all people like you and like me. They're wonderful, intelligent, gifted people like you and like me. They were able to build important things that have impacted hundreds of lives and continue to. Who knows what you all are going to inspire in this audience, because we need more regional networks to build workforce to solve local issues across the country. So these are examples of who you could be, of who your communities can aspire to be. And then we can solve those vexing issues, workforce, equity, that we feel passionate about. So as you leave today, and as you enjoy the wonderful camaraderie, the hugs, the smiles, I hope that you leave inspired that this is what your city, what your rural county, what your state can become. Thank you all. We're going to put up the QR code again for you to vote. Please, we didn't leave it up there for very long. Pull up your cameras and vote. I hope you enjoy the rest of your evening. And don't forget, 6 o'clock, we have our poetry and prose session as well if you are into poetry and prose stuff. Thank you, CFHAers. We'll see you later.